Thank you so much for the kind introduction. It's really a great pleasure to be here. And it's also a great pleasure to tell you what we've been doing the last 10 years now. And one thing that we've learned in the last 10 years is that at the crossroads of disciplines, you can really find innovation. And that's a little bit the story about Fluida, and that's a little bit the story about functional respiratory imaging, or FRI as we like to call it. And this functional respiratory imaging is essentially a combination of imaging modalities such as the CT scan, and then these methods from aerospace engineering that allow us to see like the flow simulations, the computer-based flow simulations. And we use the FRI technology to come up with better endpoints, better diagnostics for lung diseases in order to start treating those patients better. So what we use today to assess these lung diseases, and maybe some of you have done this test in the past, it's called the spirometry. And it gives us the forced expiratory volume in 1 second. So what is it? You ask a patient to forcefully exhale into a machine. We measure what comes out in 1 second, and that's pretty much the gold standard of today. So it's not that difficult to understand it. It's very hard to tell where exactly the air is coming from in the lungs. It's also very hard to tell where exactly the disease is situated in those lungs. And if we use medication like these inhalers, it's very hard to tell where exactly those particles end up in the lungs and whether it's in the right location or not. So you don't get any regional information, you don't get any images. And we've seen in the last years that that regional information, those images, they're quite important. And to illustrate that, we have this cystic fibrosis patient here. So it's a 9-year-old boy that we followed for 2 years. And you actually see that this forced expiratory volume in 1 second, so the conventional lung function test, it's quite stable. So it's around 80% predicted, so we think the patient is in relatively good condition. We also took 2 CT scans, one at the beginning and one at the end of the 2-year period. And if you then look at these FRI parameters, you basically see the following, and I'll show you in a minute how we obtain these parameters. But in the beginning, you actually see that the airways look relatively well preserved, and also those lung lobes appear to be quite healthy. Now, if you look at what happens over that 2-year period, you see almost a complete collapse of the left upper lobe and a significant increase in the deformations towards that lobe. So initially, everything was fine, and then you see the disease progression, which was not detected by the conventional lung function test. So apparently, the healthy areas in the lung still compensate for a progressing disease, making it undetectable by the conventional lung function test, but you already see it on the images. If you look at what happens to the patient afterwards, you see at one point in time, there are not enough healthy areas anymore to compensate, and you also see that the FEV1, the conventional lung function test, will go down. So we actually advocate of looking beyond the conventional lung function and then look at the overall lung health. We believe that imaging is the perfect tool to do that. Because the limited sensitivity of these conventional lung function tests, they actually cause a lot of problems. On one hand, it's very difficult and very costly to develop new drugs for asthma, for COPD, for cystic fibrosis. But also in the clinical practice, it's very difficult to assign the right treatment or combination of treatments to an individual patient. So it becomes very costly, very expensive, and very difficult to treat these chronically ill patients. As I said, about 10 years ago, we started looking into the development of functional respiratory imaging, which is a combination of the conventional high-resolution CT scans and then the flow simulations. And FRI provides us with regional information about, on one hand, the lung structure, as well as the lung function. And we believe it's a sensitive biomarker that can help us to see more in smaller clinical trials, cheaper clinical trials. And it can also help us to select the most optimal combination of treatments for individual patients in the clinical practice, thereby also reducing the associated healthcare costs. We've been quite active in looking at the obstructive lung diseases such as asthma and COPD. We also looked at bronchiolitis obliterans, which is associated with the rejection of the transplanted lung, so in lung transplantation. We also looked at the fibrosis, idiopathic pulmonary fibrosis and cystic fibrosis, alpha-1 antitrypsin deficiency, pulmonary hypertension, where the focus was on the blood vessels, and I'll show you an example of that as well. And in the upper airways, we looked at chronic sinusitis as well. So how does it actually work? So we start from these high-resolution, low-dose CT scans. And as you know, these scans can be taken anywhere in the world these days. We typically take two CT scans, one at so-called total lung capacity, so after deep inhalation, and another one after a normal expiration, so the so-called functional residual capacity. So these two scans are then sent to our servers, so the data is centralized, and we look at the internal structure of the lung. And we like to go beyond the subjective interpretation by a radiologist. So what we do, and I think that was also the theme of today, we extract the anatomical structures out of these images, we visualize them in 3 dimensions, but we again quantify them. So you visualize them, but you turn them back into numbers, and you can use these objective numbers to assess either the disease progression or the effect of interventions. You can extract endpoints that relate to the ventilation, so where is the air going to, the perfusion, where is the blood going to, the tissue, and also aerosol deposition characteristics. For instance, here, as you can see, these are the individual lung volumes, and also these lobe volumes, and we have that information at expiration and inspiration. We can also look at the vessels, as the vasculature, information extracted directly from the CT scan. We look at the airway caliber, which we can then relate to the regional ventilation pattern of an individual patient. And we can also look at the airway wall volume. So you often see in asthma or CF that the airway wall is thickened due to inflammation, bronchiectasis, etc. So what we do is we look at the lumen, we revert back to the CT scan, and we can look at the surrounding structure that builds up the airway wall itself. And again, you can visualize that and quantify that down to the level where the smaller airways start, around the 7 to 10 generation. We typically report the parameters on a lobe level. So you have 5 lobes from the right upper lobe down to the lower left lobe to really capture that regional information. In COPD, so if you smoke a lot, you get destruction of the tissue, so-called emphysema. And that's also something we can visualize and quantify. So here the dark areas represent the emphysematous regions, depicted relative to the vasculature, so you can see if there's still some perfusion left or whether the destruction of the tissue is complete. So again, you can visualize that and quantify it on a lobe level or even sublobar level if there is a need to, and see whether there is a disease progression or whether there is effective interventions. If we treat the patients with inhalation medication, like these inhalers, we can also see where the particles end up. Therefore, we attach the patient-specific upper airway. On the computer, we connect the device, and then we simulate the flow, and we simulate the particle behavior based on the patient-specific inhalation profile, the particle characteristics, the size, etc., the airway geometry, such that you end up with an effective exposure, a regional effective exposure of an individual patient. So even though it's a simulation, it has so much patient-specific information, it almost becomes a measurement, and we've also validated as such. So on one hand, the technology allows you to see where exactly the disease is in these individual lungs, and it also offers you a pathway to understand whether specific treatment will reach the correct areas in the lung. If we apply the FRI technology in clinical trials, we typically take a CT scan before and after the intervention. And this is the data that you can typically extract. So you take out the geometry from the baseline scan and from the follow-up scan. You overlay the 2 geometries, and then you can see where the differences are. And you can use these color codes to indicate regional changes. For instance, this is an asthmatic patient after bronchodilation, where we can look at the changes in the airway volume and the airway resistance. So of course, if you bronchodilate, you open up the airways, so here indicated by the red zones. And if you open up airways, it becomes easier to breathe, the regional resistance goes down, and it's here depicted by the blue zones. You can do something similar for the vessels. So this is a COPD patient after the administration of a vasodilator. So these are the blood vessels, and you can color them according to the change in the blood vessel volume. And again, you can then quantify it on a lobe level from the right upper lobe down to the lower left lobe to see exactly for that specific patient where the vasodilation occurred. The aerosol deposition characteristics that allow us to look at the regional concentration in the larger airway. So the red zones here indicate where those particles would deposit, where you have potential hotspot formation. And also the fraction that goes to the more peripheral airway, so that the deeper lung, so to speak. So if you know where the problem is in that deeper lung, you can also assess whether a sufficient amount of the inhalation medication ends up in that zone. You can look at it statically, You can also look at it dynamically. So here you see the particles moving through the airways, and here you actually see the buildup of these particles around the bifurcation and towards the deeper lung. The advantage of doing that is that based on the simulations, you can test different scenarios. So if you're a drug developer and you want to develop a formulation with a device, we can actually help you to understand what drives specific deposition. Is it the fine particle fraction in your formulation? Is it the way the patient inhales, the gradual versus a sharp inhalation profile? Is it the duration of the inhalation? All these factors play a role, and often it's a question of what drives deposition most. So if I have limited resources, where do I have to spend my resources in order to get the results that we'd like to have? We can do that in the lower airways. We can also do that in the nasal airways, where you see different angles of injection in combination with different inhalation profiles end up in different deposition patterns for these injected particles. So to summarize the FRI parameters, so just by taking the 2 CT scans, you end up with parameters relating to ventilation, perfusion in tissue, and deposition. And here they are again. So we can look at the airway volumes, the resistances, the lung and the lobe volumes, and the internal airflow distribution. From the perfusion and tissue side, we can look at the airway wall thickness, the blood vessel density, the so-called low attenuation score, which relates to emphysema or air trapping, and the high attenuation score, which is more related to fibrosis, and then also these aerosol deposition patterns. And the beauty is that all these parameters are actually coming from the same source. So you have one source of variability, because if you want to use other techniques to obtain similar parameters, you often have to use different measurement techniques, each with its own level of variability. You get variability on top of variability. You model the signal, and your sample size in your clinical trials becomes quite large. So if you have a better signal to noise by using the CT scan and then the whole range of outcome parameters, you can see more in smaller clinical trials. We also published on that, where in this asthmatic study, we calculated that instead of about 70 patients per arm, you can drop down to about 25 patients per arm. And in a COPD study, from about 91 patients to about 16 patients. So that implies that for the same amount of resources, you can do several clinical trials and use that to optimize the formulation, the device, or the target patient population. And this is something we've been doing in the aerospace world for many years. So this is now an option to also use that in drug development to come up with an optimized formulation before going into market. So if we want to look at the lung health, if we say we have to move beyond the lung function and look at the lung health, it's also important for us to understand how a healthy lung looks like. So we do a lot of research in healthy volunteers, and this is typically what a healthy lung looks like. So this is the change from expiration to inspiration. And you typically see that the airways, they shrink, but they tend to scale. So you don't see too many airways disappear, they just become smaller. Also, the healthy lobes are here colored by the lobar ventilation, so how much percentage of the incoming air is going to the individual zones. And that's actually quite constant over a healthy population. So if we know what a healthy lung looks like, we can then see what typical lung diseases do to a healthy lung. And we'll show you a couple of cases. So I'll show you first a healthy patient, then a patient what we believe would be a mild asthmatic patient, at least according to the conventional guidelines, and then a severe COPD patient. So if you look at the healthy volunteer first, so the FEV1, again, quite healthy, 108% predicted. You see a similar thing that we've seen before, so the airways, they actually scale from expiration to inspiration, not so much airway collapse. And that's what a healthy lung should look like. Now, we also had a patient with exactly the same FEV1, so you think, well, not too bad, probably a healthy patient. But you already see a very different dynamic. So you see airways disappear upon expiration, so they disappear. That means they collapse during expiration. Not something you would actually expect in a mild asthmatic patient. Because if you look at another patient, a very severe COPD patient, so a heavy smoker with a very low FEV1, you see a similar behavior, so the airways disappear. It's even more pronounced, so airway collapse, air trapping. So if you put them together, you actually see that even though, again, the conventional lung function tests say these two patients are equally healthy, you see very different airway dynamics that you can pick up with the imaging that you don't pick up with the conventional lung function tests. And does it matter? It matters a lot, because mild asthmatic patients, we typically treat with these inhalers. But if you have very collapsible airways, what actually happens if you use an inhaler, you actually have hotspot formation. So all the medication is pretty much concentrated in certain discrete zones. So you will have chronically undertreated areas in the lung. So what's now a mild asthmatic patient will very rapidly become a more moderate or severe patient. So it is important to know what actually happens. Regional information in respiratory matters a lot. A few more examples: cystic fibrosis, so the mucoviscidosis. So this is a cystic fibrosis patient, and this is a matched healthy volunteer. So you actually see that the healthy lung is very active, is very dynamic from expiration to inspiration. In the CF lung, you hardly see any movement. So the mucus actually causes very much hyperinflation, specifically upon expiration. So again, you see sharp differences between a diseased lung and a healthy lung. And also, again, the regional information is quite apparent. If you look at the airways of this patient, then it's not surprisingly why the patient suffers so much upon expiration. If you look at the deformation, the bronchiectasis in these airways, it's quite pronounced, especially compared to the matched healthy situation. Another lung disease is IPF. And IPF is actually kind of a nasty disease. So the survival rate or the survival time from diagnosis is about 3 years. So if you get diagnosed with IPF, your outcome is not looking well. If you look at the lungs itself, you actually see again the IPF patient here with a matched healthy volunteer. And here you see that the lung lobes are significantly smaller. It's a so-called restrictive disease, so the lungs do have problems with expanding. And again, you see the differences in terms of the color codes when you compare the regional lobar ventilation with a matched healthy volunteer. So again, the FRI technology allows you to see what happens and to see where the differences are in terms of the lobe volumes, in terms of the airway volumes, etc. So a crucial thing, as you all know, in the biomedical space, what do the regulators think of this? We often get questions and ask for a good question for afterwards. A question that we always get is, what do the regulators think of this? And for many years we had to say, yeah, we're talking to the regulators and we're moving forward. But since a couple of months we actually made some good strides with them. So in May of this year, the FDA came out with guidance for industry around the development for drugs for COPD. And now they actually state that the primary efficacy endpoint can be a sensitive radiological assessment of lung structure with supporting evidence that the regenerated lung tissue is functional and that the treatment provides clinically meaningful benefit to the patient. So if by study design you can demonstrate that whatever you see in the images is clinically meaningful, then this becomes a primary endpoint. It's quite different from the past where imaging was normally a supporting endpoint, but now it becomes a primary, and that really will push the imaging in the respiratory space quite forward. We also had the support of the FDA in a letter of support for our IPF work, where they actually, again, they encourage the exploration of our FRI parameters in the IPF technology to evaluate disease stage and progression, biological response, therapeutic intervention, etc. So there is a move towards these image-based endpoints. What we also realize is this can only become mainstream if we provide a platform to the individual physician to use the technology, to make the technology theirs. And that's why we recently developed the BronchoLab application, which is an online platform where individual physicians can actually log on to, they can sign in, log on. They can upload the CT scans of their individual patients and then look at the results, looking at the comprehensive set of parameters. So you have the asthma, COPD, IPF, and CF population that we typically look at. And for an individual category, you can then look at the scans of that specific patient. So very much personalized medicine. So this is, for instance, a case of a COPD patient. Every line represents a CT scan. So this patient had 3 measurement points. And for each of the measurement points, you can then, as a physician, look at the comprehensive set of parameters. Again, the lobe volumes, blood vessel densities, and so on. And the way it's built up is that as soon as you go into a parameter, you see the results of your own patient. Immediately, you also see the matched healthy volunteer. So here, for instance, this is the patient, and this is the matched healthy volunteer. So immediately you see where the problem is, hyperinflation. The lungs are too large. And then you can also look at the numbers to see where exactly the problem is. And that you can do for all the parameters. And as a physician, you can then use the technology to understand what combination of parameters or treatments is most suitable for the individual patient. So in conclusion, I think we definitely need a paradigm shift from just looking at the lung function towards looking at the overall lung health. I think the FRI can be a very good tool to do that. And it can be used in both the obstructive and the restrictive lung diseases, so it's quite applicable over the whole range. Also, if you look at the inhaled aerosol deposition patterns, the FRI can really understand how the diseases affect the deposition patterns. We see that the regulators are starting to follow this line of reasoning, that an image says more than 1,000 words or 1,000 lung function tests. And now with the BronchoLab, we can also start using the FRI or offering the FRI in clinical practice. So I think taking it all together, also, of course, with the good partnership we have with Materialise, I think we have the critical mass to make sure that we can now really shift that field from more ancient technology to better technology and really create the critical mass to come up with those better endpoints and to make sure that the patients receive the better treatments, they stay healthier for a longer period of time. And that, at the end of the day, was the reason why we started the company in the first place. And as far as I'm concerned, it will always be the reason to keep going. So thank you very much for your attention.